Hey guys, welcome back to part 13. Let's hop right into it with some blood products. I think people usually talk about transfusion reactions, and that's definitely high yield, but also knowing what the blood products are and when to give them is another important topic that I'm seeing starting to get tested more often now. So really there's a couple different types of blood products: whole blood and then fractionated blood components. Most of the time you're not going to be giving whole blood. I've rarely ever seen whole blood even mentioned on exams unless it's a wrong answer. Most of the time, unless it's an extremely critical transfusion situation and you have nothing else, you want to give a fractionated blood product to replace the most important thing that they're losing. Okay, so different fractionated products, right? Packed red blood cells, fresh frozen plasma, platelets, all of these are parts of blood that you will replace in a transfusion. So PRBCs are by far the most common thing that's given in hospitals. So let's start there. Now the important thing to note here is that there's different types of PRBC you can give, right? Always remember to type in cross-match before you give a transfusion product, and also make sure you're giving the right type of PRBC. So there's just regular old run-of-the-mill PRBCs. There's leukocyte-reduced PRBCs. There's irradiated ones. And then if you're giving a mixed blood product, there's washed as well. So I'll cover these three subtypes: leukoreduced, irradiated, and washed, because I feel like they're important and I've seen them tested. Leukoreduced PRBCs essentially filter the PRBCs where the white blood cells are getting removed. And what you want to do, what you accomplish by doing this, is you reduce the risk of non-hemolytic febrile transfusion reactions and also viral transmission, because some viruses like to hang out in WBCs, like CMV, HTLV1 and 2, EBV. Those are all viruses that hang out inside of leukocytes. You're preventing transmission with leukoreduction. Okay, so if you want to prevent transfusion reaction, if the person has a history, you want to go with a leukoreduced product. Okay. Now, what about irradiated products? Irradiated products are used to kill lymphocytes. So instead of filtering them out, we're just straight up murking them with radiation, okay? Because they have nuclei, red blood cells don't. That's how we're inactivating them. And what you're aiming to do here is to give a person who's immunocompromised irradiated products, because this will prevent reactions as well as graft versus host if they have any kind of transplant. Okay, so transplanted patients, irradiated; leukoreduced for people with previous reactions and viral risk. All right, and then there's washed. Washed products are essentially, what that means is they take the plasma, they remove some of the protein products, some of the antibodies out of it. This is mainly used for people with IgA deficiency who are at high risk of anaphylactic transfusion reactions. So they're going to remove the IgA from the blood product in order for that person who's receiving it to not just get a whole host of foreign IgAs and activate an anaphylactic reaction. Okay, so that's a washed product. One more time: leukoreduced, non-hemolytic febrile transfusion, and people who are at risk of viral transmission. Irradiated in immunocompromised graft versus host disease, and washed, IgA deficiency for anaphylactic. Okay, those are the three ones that I think are important to know. When do you transfuse? So you transfuse at less than 6. You don't even think about it. Boom, transfuse 1 unit. Less than 6, definitely. 7 and 8. 7 is if they're symptomatic. You're going to transfuse at less than 7. And if they're if they have cardiovascular disease, you're going to transfuse at less than 8. So 8 cardiovascular, 7 symptomatic, or some places just transfuse at 7 as their base threshold anyway. Most people in the hospital have some kind of symptom, right? So 7 is at base or symptomatic, and 6, don't even think about it, less than 6 transfuse, okay? Jehovah's Witnesses are people that are kind of a special category where you really can't transfuse all the time. So make sure you ask them if they have this religious association, because then you're going to have to pursue other routes of keeping their blood cell count higher. Okay. Fresh frozen plasma is another group of transfusion products. So this is the plasma part of our blood. And this is used in sort of one main situation, where you have an anticoagulant that you want to reverse, like warfarin overdose, for example, and they're actively bleeding, so you want to give them volume. So fresh frozen plasma has two things. It has volume and coagulation, anticoagulation reversal. All right. There's also products like cryoprecipitate, like prothrombin concentrate. Those are types of anticoagulant reversal where you have less volume. So what kind of person do you not want a volume overload with FFP? Heart failure patients, renal compromised patients, right? Then you want to really consider, am I giving fresh frozen plasma, or am I going to give prothrombin concentrate, cryoprecipitate, one of these other things that has less volume in it? I don't want to put too much pressure on those organs. All right, so if you're actively bleeding, you're actively losing a lot of volume, FFP is a great option for something like a warfarin reversal, okay? One thing that's important and that you need to consider for FFP, you need to do ABO compatibility. That's another downside. For some of these other anticoagulant reversals, like prothrombin concentrate, you don't need to do ABO compatibility, you can just give it. For this one, remember the antibodies are just floating around there. The anti-red blood cell antibodies, your ABO blood group antibodies are floating around in the plasma, so you definitely need to have compatible at plasma in that case. They'll try to trip you up, watch out for that contraindication, okay? Platelet transfusions are for thrombocytopenia. Usually you wait for a platelet count about 20, 40 in order to give platelets. If the person's having blood loss and low platelets, the threshold is higher, obviously, right? Cryoprecipitate we talked about already. It has a bunch of clotting factors and not a lot of volume. It has fibrinogen, fibrinogen, factor 8, factor 13, von Willebrand factor, and fibronectin. So it's great for anticoagulation reversal. You can give stuff like specific clotting factors if you know what the disease is, and if you have like a specific disease, if you have low factor 7, you can give just factor 7, or low factor 8, you can just give just factor 8. Antithrombin 3 is one of those cases where, you know, if you have low antithrombin 3 or like a hereditary antithrombin 3 deficiency, you can give antithrombin 3, right? If they're bleeding out, that's a genetic anticoagulation, right? You can give them specifically one type of factor if they're just missing that one. Okay. All right, so the next thing I want to talk about is pulmonary hypertension. It's a great test question because you can get cor pulmonale from pulmonary hypertension. The number to remember here for the pulmonary arterial pressure is 20. Normal pulmonary arterial pressure sits at around 10, 14. You can just remember 10 for easiness sake. So normal pressure is at 10. If it's above 20, it's hypertension. And what can that cause? It can cause something called cor pulmonale, where the right atrium and right ventricle are now under a lot of strain, pushing against this high pressure. Can cause right heart failure. You're going to see JVD and things like that. All right. So high pulmonary vascular resistance can be due to a bunch of causes. Vaso-occlusion is one of them. Hypoxia is another great one. When you're hypoxic, the vessels constrict to kind of shunt flow into places that are getting more oxygen. Inflammation can cause hypertension. Inflammatory cytokines are great vasoconstrictors, and high endothelin in endothelial dysfunction diseases is another etiology for this disease. Okay, so how do we treat? What's another important thing before we talk about treatment? When you increase pressure in the pulmonary circuit, you're going to increase right ventricle afterload. You're going to cause dilation of the right heart, and then this can lead to arrhythmias. Remember, the SA node and the right side of the Purkinje system is on the right side of the heart, and if you're dilating all of that, you're at a great risk for arrhythmia. So pulmonary hypertension, the main causes of death here are arrhythmias. All right, so that's a very good point to remember, that pulmonary hypertension is linked to arrhythmias. Remember that the MPAP, or the pulmonary artery pressure greater than 20, is diagnostic. You're also going to see dilated vasculature in the chest x-ray and the echo, you'll see hypertrophy of the right ventricle and a prominent right heart border on chest x-ray. Okay. Treatment. So there's a bunch of different ways to treat. You really want to start treatment on this kind of disease early before irreversible changes start to occur, because after some time you're not going to be able to help much. You're just keeping this disease at bay. Oxygen therapy is great to help keep those airways highly oxygenated and stop the buildup of CO2, which vasoconstricts. Diuretics is also good to prevent cor pulmonale, to prevent fluid from building up and causing the right heart to have too much strain. Be careful with diuretics though, because over-diuresis can cause underfilling of the right ventricle, decreasing cardiac output, and further causing complications like renal failure and things like that. So diuresis is a fine balance in this kind of disease etiology. Now, the drugs that they'll test you on for this are probably going to be calcium channel blockers, endothelin receptor antagonists. A great example is bosentan. This is going to help dilate those pulmonary vascular blood vessels, and PDE inhibitors. So PDE phosphodiesterase 5, we already talked about phosphodiesterase in this series once, but things like PDE5 inhibitors like sildenafil, which are usually used in erectile dysfunction and also have great use in pulmonary hypertension, remember that. And what you want to be careful with here is if you're going to use a PDE5 inhibitor, you want to make sure that they're not on any kind of alpha blocker or any kind of nitrate, because this can precipitate really life-threatening hypotension, okay? So PDE5 inhibitors, be careful, look for contraindications. Prostacyclin analogs like latanoprost, isoprost, those are great ones as well. And synthetic prostacyclin like epoprostenol is also a good option. Remember, these also have uses in clinical critical limb ischemia. All right, so we've covered pulmonary hypertension. I think it's a good enough review for some of the key things to remember. Now, a lot of the times, something that I see tested and where they like to throw a lot of numbers is the different pressures in the heart. So they'll give you a pressure of the right ventricle, right atrium. They'll give you numbers. So remembering a couple of the numbers in the heart for pressures, I think is helpful in deciphering certain questions. How many millimeters of mercury is each heart chamber usually pressurized at? Okay. So before we start that, I want to remind you that pulmonary capillary wedge pressure and central venous pressure are important numbers to remember, and that central venous pressure is a right atrial pressure, and that pulmonary capillary wedge pressure is a left atrial pressure. Okay. So this will help you a lot in deciphering what they mean when they say those words in a question stem. Now, the numbers to remember for the right heart and the left heart are decently straightforward. I'll give you nice round, easy numbers so that you can just estimate if it's way out of that range, you know you're dealing with a hypertension on either the right or left side. So the right heart, the right atrium, if you remember the number 5, you're good to go on that. And the right ventricle is 25. So 5 millimeters mercury for the right atrium, 25 millimeters mercury for the right ventricle. Those are the max pressures, okay? 0 to 5, 25, 0 to 25 also in the right ventricle, okay? Now the right ventricle and the left ventricle, you should know that their pressurized difference is pretty high, right? So the left ventricle, which is pumping blood to the whole system, you can remember 100 to 120, that's kind of your range. But if you want to keep it nice and round, 100. And then the right left atrium is 10. So right atrium, 5, left atrium, 10, right ventricle, 25, left ventricle, 100. Okay? So 5, 25, 10, 100. All right. That'll help you remember. If you remember those nice and round numbers, you'll kind of have a ballpark understanding of what they're talking about when they speak about certain pressures within the heart and what they normally should be. Remember, pulmonary capillary wedge is referring to the left atrial pressure, and that should be, somewhere in the ballpark of 10 to 15 maximum. So you can add 5 to have the maximum range. And then central venous pressure should be somewhere in the ballpark of less than 10. So 5, you can add 5 to 5 and have less than 10 as your threshold for that. Okay, moving on. So those are the heart pressures. I think they're important to remember. And now I hope that was a good, nice, quick review. Narcolepsy. Now I've seen narcolepsy start to get more popular now in question stems. Narcolepsy is primarily a disease found in men, right? It has a bimodal distribution at around 15 and 35-year-olds. So 15 is one mean, 35 is the other. Just know that it's bimodally distributed. There's 2 types of narcolepsy actually. Type 1 is an orexin deficiency. So an important pathophysiology question, if they give you a narcolepsy question and the question asks you, what would you find in CSF? You would find low levels of orexin, okay? So remember, orexin is the awake hormone in the brain. Type 2 narcolepsy is idiopathic, so really type 1 is the one that gets tested most of the time. Remember that some genetic syndromes are associated classically with narcolepsy, namely Niemann-Pick, Prader-Willi. Those are some great ones to remember as associated with narcolepsy. You get excessive daytime sleepiness in this disease, where you have sudden onset of sleep attacks. This sleep lasts for about less than 30 minutes and occurs totally inappropriately. So you'll be sitting down at a table, boom, fall asleep. Okay. In addition, you have abnormal REM cycles, so you go into REM a lot faster. There's something called cataplexy that happens, which is sudden muscle weakness triggered by strong emotions. So if the person's laughing, if the person's crying, and then boom, they go limp, that's a narcolepsy indicator, right? Sleep paralysis is very common here with sleep hallucinations. So hypnagogic and hypnopompic. There's 2 types of sleep hallucinations. If you're gogic, you're going to sleep. So this is when they're falling asleep, and pompic is when you're waking up. So you're popping up awake. Go to sleep, pop awake. All right, that's how I like to remember those 2. Okay, and you generally want to do a sleep study for these people. That'll help you with the diagnosis. Polysomnography is great, and then you can also do something called a multiple sleep latency test for a person with excessive daytime sleepiness, which will help to diagnose it. If they have a mean latency of sleep of less than 8 minutes, that's pretty diagnostic. The general approach to treating narcolepsy is really CNS stimulants like modafinil. You can also use methylphenidate. Other amphetamines are preferred amphetamines are usually preferred in children, so methylphenidate and amphetamines. Modafinil is a non-amphetamine stimulant, so it's usually more of an adult drug. But 15-35, so if the person's over 18, you'll go with modafinil. If the person's pretty young, 15 or younger, you'll go with methylphenidate and amphetamines. Okay. If you want to treat specifically cataplexy, sleep paralysis, hallucinations, you're going to go with an SSRI, SNRI, and sodium oxybate is pretty effective for cataplexy. But what is sodium oxybate? I know a lot of you probably haven't heard of this drug. Really what it is a GABA direct agonist. It's also known as what's it called? It's also known as ecstasy, liquid ecstasy. Okay, so GHB. It's a direct agonist of GABA. It has a high misuse potential, so you have to be very careful with sodium oxybate. So you're giving a person not with narcolepsy ecstasy, but you have to be careful because it's life-threatening if they use it with other depressants like alcohol, benzos, barbs. So try to avoid it if you can, but if it's severe cataplexy and there's no other alternative, sodium oxybate is there for you. Okay. Let's talk about, what should we talk about next? Let's talk about some bowel problems, okay? So things like SIBO, small intestinal bacterial overgrowth, is a good topic, very commonly tested. essentially this is overgrowth of bacteria in the small intestine. And if you have a lot of pouching in the intestine, a lot of diverticula, you can have blind loop syndrome, where these bacteria like to grow inside of diverticula close to the small bowel. If you have diverticulitis of the small bowel or any kind of blind loops in the small bowel, you can have problems with that. The pathophysiology here is important because you have decreased absorption, right? This is lower B12 levels are found here. Fat-soluble vitamins are essentially going out the window. Zinc and iron also are malabsorbed in this kind of situation. And an interesting thing here is that you have increased deconjugated bile acids because the conjugated ones are absorbed in the small intestine, reabsorbed. Okay, so if you test for bile acid, that's going to be a common finding there. How do you manage SIBO? Well, antibiotic therapy is the mainstay here. And you want to do supplementation for those vitamins that you are losing. Next, let's talk about dumping syndrome. Dumping syndrome is basically rapid gastric emptying in someone who's had any kind of gastric surgery. Basically, the pyloric sphincter is not working well in dumping syndrome. So you have rapid emptying either rapidly after meals or with a little bit of latency, which is called late dumping. And in this case, the patient is going to be hypoglycemic and have a recent gastric surgery. So low blood sugar, recent gastric surgery, that's boom bam, you've identified dumping syndrome. Okay. All right. What else should we talk about? Spasticity. Spasticity is a great topic. You see spasticity in people who've had strokes, cerebral palsies, brain tumors. MS is a very spastic disease. ALS is also a great one. So these people have the kind of clasp knife phenomenon where a limb, when you move it rapidly, it's going to lock up, and then moving slowly afterwards will decrease the resistance. So rapid movements of limbs causes rigidity in spasticity syndromes. Okay, and how do you treatment? So treatment is a really good host of drugs here. Baclofen is a great one. It's a GABA B agonist in the spinal cord. It's going to help with muscle spasticity. It's a muscle relaxant, right? Dantrolene is another one that can help. Cyclobenzaprine is a great one because it's a 5-HT2. It works through a different mechanism. It's basically a 5-HT2 agonist in the central nervous system, which helps with spasticity. Because remember, in the central nervous system, if you have a damage there, you have decreased inhibitory firing. So the muscles can become overactive, and there you get spasticity. Alpha-2 agonists are also great. So things like tizanidine, which is an alpha-2 agonist, clonidine. These guys are great for muscle spasticity, cerebral palsy, ALS. You'll often see them used in those kinds of cases. And benzos are less commonly used, but also a potential option. Okay? So those are the spasticity drugs. Now let's talk about TB. TB is kind of a huge topic, so I'm just going to focus on certain subtypes of TB and some high yield points that I think are less commonly emphasized, making them great for testing. Okay, so you get a TB patient in your office. They're going to have low-grade fevers, night sweats, weight loss, decreased appetite, shortness of breath, pleuritic chest pain, pulmonary TB. That's your classic pulmonary TB, but TB can go to so many different organs and locations. They're great for test fodder. So you can have lymphatic TB, where the TB likes to localize in the lymph nodes. You'll get lymphadenopathy, cold abscesses, sinus tracts that are draining weirdly. So anything that looks kind of weird and you expect an infectious etiology, TB is not a bad idea to test. TB can also cause things like TB pleurisy or TB pleural effusions, miliary TB. This is TB with multiple organs that are involved, right? So if you have the lungs and the liver is a great spot for miliary TB. You always want to get a LFT panel. You'll see hepatosplenomegaly in these cases. Chest x-ray will show these really small, kind of peppery 2 millimeter nodules resembling millet seeds. That's why it's called miliary. So you're going to get a peppering of nodules everywhere. In miliary TB, you can get pericardial effusion. It can go to the heart. It can go everywhere. You have definitely high ESR, CRP in these people, and definitely check LFTs. If you're suspecting miliary TB, go for LFTs. It'll help you with the diagnosis. Okay. It's 20% of cases of extrapulmonary TB, and a lot of the cases are where you have a reactivation, and then the reactivation goes out of nowhere. Like say the person's immunosuppressed, has HIV, biliary TB can spread from that. So lungs, spleen, liver, lymph nodes, adrenals are places where the TB loves to spread. Also, don't forget Pott's disease, where it goes to the vertebrae. That's another great TB spreading question. So adrenal TB is important one because it can cause adrenal dysfunction. You have low steroid production now. You have low aldosterone. So watch out for electrolyte disturbances. And an interesting note here is that rifampin can actually precipitate adrenal crisis if the person has an undiagnosed adrenal TB. So let's say you're treating what looks to you like pulmonary TB. Okay, you give them the right therapy. Now they have adrenal problems. They come back with sodium that's out of whack, cholesterol, cortisol that's going crazy. What's going on? Well, you gave them rifampin and they had adrenal TB the whole time. Okay, and remember that TB also has a whole host of dermatologic presentations. So lupus vulgaris is there, where you have kind of face and neck rashes that are plaque-like and have ulceration and scarring. Scrofuloderma is another one that's pretty much highly tested. This is kind of a involvement of the skin that overlies infected structures like the lymph nodes, joints, the epididymis. These ones are essentially TB that's presenting on top of where the infection is. You'll have firm nodules in that area with potentially draining sinus tracts. That's called scrofuloderma. Okay, so remember lupus vulgaris and scrofuloderma. They're one of the more highly tested things in TB. Okay, what else did I want to talk about with TB? Oh, active and latent. Okay, so a lot of people know the treatment for active TB, the ripe therapy, but latent TB is where they like to catch you because there's a couple different options for treating latent TB. Everyone remembers isoniazid for 6 months or 9 months. That's a latent TB therapy, but there's other options, and they like to throw in the other options on the exam because they hate us. So rifampin and rifabutin are both rifampin sort of analogs. Rifabutin is more powerful, so you can do isoniazid plus rifampicin. Rifampin, rifabutin are similar compounds. Rifampicin is a related compound that's more powerful. So if they throw rifampicin at you, not rifabutin or rifampin, rifampicin is more powerful, okay? And isoniazid plus rifampin you can do once weekly for 3 months. That is one of the shorter courses for latent TB, so it's really highly preferred. You can do rifampin for 4 months on its own, or rifabutin for 4 months, and isoniazid plus rifampin, not rifampicin, for 3 months. So rifampin, rifabutin, rifampicin, all those you can consider sort of rifampin analogs. Rifampicin with isoniazid once weekly, so the dosage is not as frequent for 3 months, right? So you only need to do 12 doses. And rifampin on its own, this one you need to do daily for 4 months, and isoniazid plus rifampin is daily for 3 months. So if you don't want to take something daily for 3 months, you want to take it weekly, you're going to switch rifampin to rifampicin with the isoniazid, right? And if you only want to take one drug on its own, you can do rifampin daily for 4 months. So the shortest course is isoniazid plus one of the rifampin analogs for 3 months, either once weekly or once daily, depending on the analog. And you can also do 4 months of rifampin. Very commonly tested is 4 months of rifampin, right? 4 months of rifampin, 9 or 6 months of isoniazid. Those are the most common regimens you see on the test. Watch out for those, okay? All right, in the next podcast, I think we'll cover analgesic nephritis and crystal-induced kidney injury. These are both kind of tubulointerstitial diseases that like to pop up on the exam, and I'll leave that for the next podcast. Hopefully this was helpful to you, and I'll see you in the next one.